In most healthcare settings, it is unnecessary and time-consuming for nurses to perform daily head-to-toe comprehensive physical assessments. We talked about this. There just isn't enough time. Instead, nurses perform systematic, routine, essential assessments with focused assessments based on the individual needs. So, students will perform an accurate, thorough yet succinct bedside physical assessment that mimics real-life practice. Additionally, students will document their assessment findings using standards of practice guidelines. So, the first part is, as far as the guidelines, you'll be doing this within 30 minutes. That's way more than enough time. You'll take short notes during the assessment because you will be also submitting documentation, and there is a rubric for that. I will observe and not answer assessment questions. I mean, I'll answer questions before, but once you start, you should just kind of run through it. You will not be penalized if you do not follow the assessment guide in order, and that's how we've always been. If you are going through this head to toe and you forgot the respiratory and you go back, that's fine. I just want to make sure that you cover all your bases. You will be assessed on your ability to perform the psychomotor skill. I do expect that you guys should be able to do this now, and really you've checked off on all aspects of this, so it's just putting it together. You will have 3 attempts to pass the physical assessment and written documentation before you take the final, and you must achieve a 54 out of 60 on the actual psychomotor part. So what that means is if you look at the bedside physical assessment on 67 and 68, you'll see this, I guess you could call it a rubric or outline, and each section is broken down into bullet points, and then there are corresponding points in that last column. So the total is 60. In order to pass the psychomotor checkoff, you need to achieve 54 out of 60 points. And you don't actually get these points in your grade. It's pass fail, but in order to pass, you do have to get 54 out of 60. Does that make sense?
Yes.
Mm-hmm.
Okay. So you can see that it's really objective. There are bullet points corresponding to the points. On page 70 and 71 are the documentation guidelines. Documentation must be submitted after you successfully check off on the physical assessment. It should be factual, accurate, concise, complete, current, and organized using the template. Your documentation should correlate with the different sections, which correlate with the sections on the psychomotor skill. And this is due, just like all our other documentation, by midnight the next day. In order to pass the documentation part, you must score an 18 out of 22. So you can see that there are 3 columns. The first column, proficient, is 2 points. Second column, needs improvement, you'll get 1 point, and third column is 0 points, unsatisfactory. Any questions about this? It's pretty straightforward. If you follow the rubric, it's pretty impossible to not pass the documentation. Okay? You'll notice on the next page there is a copy of the Braden scale, which is a part of this assessment. And then there's also on 73 a copy of the Morse-Fall scale. There's also a copy of the Glasgow-Coma scale. You probably already knew that on page 74. So you can refer to those as needed. All right, so let's just go through this assessment then. And you will not be learning anything new in this assessment. We're just putting together the points that you've already checked off on your focused assessments. So the first part of this assessment, on page 67, do you have a question?
No, I wanted to record it. So.
Oh, okay, yeah, no problem. You can record it.
I don't know how long.
Yeah.
It's going to be long, so you should probably record it.
We're going to do it on each other. I'm just going to demonstrate right now on the mannequin so everybody can take notes or whatever. So the first part of this assessment is going to be the introduction. So I think of this partly outside the room and then just walking in the room to do the usual introduction things. So before you even enter your patient's room, you are going to want to have some idea of certain things. You are going to want to know generally, is this patient on any isolation? You're going to be aware of safety issues. That's, again, one of our CUSIN competencies, right? Fall risk. Is this patient a fall risk? And also probably the patient's code status. We are going to want to have a general idea of why this patient is here, so the admitting diagnosis, and then any major health deviations is the way it's worded here in that second bullet point. What do you think that means, major health deviations? Any thoughts?
Like health concerns.
Yeah, be a little bit more specific.
Obesity, diabetes.
Diabetes, like obesity, yes. Any congestive heart failure. So any major health issues or health issues that may affect your care for this patient, even though that might not be why the patient was admitted. Do you know what I mean? So like this patient, let's say, was admitted for abdominal surgery, but is a diabetic. We are going to have to be aware of his diabetes when we're caring for him. We're going to have to know about, what type of insulin he's on, when he's getting his insulin, when he's getting his meals, that the diabetes might affect his wound healing. So that's what we mean by major health deviations. We also want to be aware of using safe body mechanics when we're dealing with a patient, moving him or just doing our assessments. Always want to have the bed at a good working height. So I will then, like we've done with all our assessments, knock on the door, introduce myself, provide privacy, explain what I'm going to be doing, wash my hands, and ask if he has any questions. And then I will go ahead and move into the patient identification, name and date of birth, and assessing for any allergies. Okay, so that's all the introduction part. Those are things you've all done. Maybe a few more introduction points to be aware of. Then I'll move into my general survey. So, just as a review, the general survey, remember, is what?
Inspection.
It's like your first impression, right? Mm-hmm. And there are those different categories of the general survey that we're kind of taking a quick look. So I'm noticing his age, his race, his gender. I'm noticing if he's in any distress. I'm noticing any facial grimacing. I'm noticing his general body type. I'm sort of all looking at this. I'm noticing his behavior and appearance and the way he's interacting with me and his appearance, like his dress, his hygiene, any body odor. I am also noticing his speech. I'm noticing a couple things about that. Is he articulating appropriately? And, is he answering questions appropriately? And then I'm also noticing his affect and mood. So the general survey part of this will be kind of more verbal. You'll be, sort of stating all those things that you are assessing that make up the general survey. And that will account for 4 points. Then I'm going to go ahead and perform a full set of vitals, pulse, respirations, temperature, O2 saturation, pain, and blood pressure. That will be 4 points too. You don't need to do the 2-step, you can just do the 1-step. The next section is height and weight. So we don't actually have to obtain that, but you can just state that you're aware of the patient's height and weight and that you've either looked in the chart or you got it. One other thing I forgot to mention for general survey was the patient's posture and gait. So you would notice the gait. I mean, patient's in bed, obviously you're not going to notice the gait, but what reminded me was, like, if you were going to get the patient's weight, you could assess their gait then. Okay.
So are we saying, like, the person is 54 years old, they're a white person, do we go through and state all
Yeah,
that
those
then?
points,
Okay,
yes.
I just want to make sure.
Yep,
Okay.
yep. So then we're moving into the heat and neurological is combined here, and in real life that would probably be the case too. You could combine those two, that's often done. So the first thing that I'm noticing about him is going to be his level of consciousness. Is he awake? Is he alert? Is he lethargic? Is he obtunded? Is he comatose? The second bullet point here is Glasgow Coma Scale. when do we use that? What is it, first of all, just as a review?
Just to see like the alertness of a patient.
Right, so it's an objective way of communicating a patient's level of consciousness. It's mostly used in situations where the patient is unconscious or affected somehow. If someone is awake and alert and oriented ×3, we don't need to use the Glasgow Coma Scale. So I want you to be aware of what it is and just state that you would use that if the patient were unconscious or altered somehow. You could use the Glasgow Coma Scale to communicate objectively the level of consciousness. Does anyone remember what the best score of a Glasgow Coma Scale is?
15.
15, good. Does anyone remember the 3 areas that we look at on the Glasgow Coma Scale?
Eye opening.
Eye open,
Following commands.
following verbal commands, and
Movement.
best motor response. Yeah, so muscle movement, best motor response. Good. All right, so we've established that he's awake, and so I've established his name because I've asked some, can you tell me your name and date of birth? And are you allergic to anything? So, Mr. Miller, do you know where you are? He's saying he's in the hospital. And can you tell me the date? So now I've established
A0 ×3.
×3. Do you know why you're here? That would be ×4. Okay, so oriented to the situation is ×4. So I do want you to assess that and understand, in order to document oriented ×3 or 4, you have to ask the questions, you cannot just assume. So now I'm going to begin with my inspection of Mr. Miller, and I'm thinking heat and neuro, so I'm just kind of looking at him, I'm looking at his face, I'm looking for any obvious asymmetry or facial droop or an eyelid droop. What's the name for eyelid droop?
Ptosis.
What'd you say?
Ptosis.
Ptosis. It's PT, but it's pronounced ptosis.
Okay.
So you are correct. Ptosis would be an eyelid droop. I'm noticing that. And then I'm going to do a quick check of his eyes. So Mr. Miller, I just want to take a look in your eyes, if you don't mind. If you can look straight ahead and don't move your head. And I'm going to shine this light briefly in your eye. So I'm first of all looking at his pupils at rest, and I'm looking at the size, the shape and the size at rest, and that if they are equal or not. So I'm seeing that his pupils are round, equal, 3 millimeters at rest, and I'm shining the light in his eye. And I notice that the right eye and the left eye are both constricting to a 2 millimeter. That's what we would expect. And then I'm going to also check, I'm sorry, that was the left eye. And then I'm going to check the right eye and just briefly shine the pen light in his right eye, and I notice that it constricts to 2 as the left eye. So we look at the direct response and the consensual response. If that's all intact, how can I document that? PERLA. You don't need to document PERLA and then write out pupils equal, round, reactive to light, and accommodation. You just document PERLA. In order to actually do PERLA, though, you have to do the accommodation piece. So Mr. Miller, keep your head straight again, please, and then can you look at my pen about 6 to 12 inches away from his eyes? And I'm noticing that his pupils are constricting, getting smaller, and converging. And then Mr. Miller, look at the far wall, and I'm noticing that the pupils are getting bigger. So they're dilating when he's looking far. Okay, and that's the accommodation piece of PERLA.
So do we have to do ELM and all of that?
Yep, I'm just getting to that now. So now the other quick test that we're going to do is assessing for extraocular movements, and we do this by the 6 cardinal fields of gaze test. So Mr. Miller, just keep your head straight here, and can you follow my pen? And he's moving with his eyes, they're moving together. I'm not noticing any nystagmus, which is that quivering. And I'm just, there you go, very nice. All right. Eyes, so now I'm going to quickly assess his hearing. And I would ask him if he's had any difficulty with his hearing, or if he wears any hearing aids. I'm also kind of assessing his hearing because I'm noticing if he's responding to me. Now I'm going to we don't really necessarily assess the nose as part of this quick head to toe. We're gonna move on to the mouth. And one important point is swallowing. So, Mr. Miller, have you had any issues with swallowing? And he said he has not. I'm going to then, as part of my neuro, I now think, movement, strength. So I want to ask him to squeeze my hands, check his bilateral hand grasp. So can you squeeze my hands? And then I'm going to quickly move to check his upper extremity movement and strength. So he can lift his arms up, bend his elbows, and then I'm going to ask him to resist my pushing down, and then same with pushing, resist me from pushing you. Now at this point, I could also then move right down to assessing his lower extremity strength. So I could have him push against me, and then same thing, pull up. And if he's like, if your patient's in bed rest, you could actually have them bend up their knee and then push against you, and same with the other leg. We're always trying to compare both sides. So at this point, you could also do like the cardiovascular aspect of the assessment on the lower extremities. I don't want to confuse you, so that's up to you. So right now, I'm just going to go in order of the book, but when you're practicing, when you're down here, you could do like skin temperature, edema, pulses, capillary refill of the toes. You could do that right now, but if it makes more sense to you to just do that all within the cardiovascular aspect, that's fine too. Okay, so we now want to do a quick coordination test as part of the neuro assessment. So Mr. Miller, can you touch, I'm gonna have you touch your nose and then touch my finger. I'm gonna move my finger a little bit. So, he's gonna touch his nose, touch my finger, touch his nose, touch my finger. You can just do that in bed. For lower extremity, you can do this coordination for lower extremity while someone's sitting or in bed. Just have them rub their heel up and down their shin on both sides. And then the Romberg test, if necessary, you would have to get them to stand up though. That's not always necessary as part of our routine test, but we do have it in here. So remember the Romberg test assesses what?
Balance.
Balance, good. And to do it, what do we do?
Stand and close our eyes for 20 seconds.
Right.
Close your eyes.
Stand with your feet about hip width apart, your arms at your side, and you're going to close your eyes and you're going to assess if the patient is at all swaying. So they should be able to stand with their arms at their side with their eyes closed for 20 seconds, no problem.
Are we doing this one when we're doing the testing?
Yeah, so
Okay.
you should do this one just when we're doing the testing,
Okay.
yeah, so the Romberg. And then the last part of the neuro quick assessment is going to be that sharp, dull sensation. And yeah, it's on here, so we're just gonna do it. So the sharp dull is, remember, Mr. Miller, this is dull and this is sharp. I'm gonna have you close your eyes, I'm gonna touch various parts of your body, and I'm gonna tell you, you tell me where you're feeling it and if it's sharp or dull. So he's doing it, and I'm gonna do a couple on his face, a couple on his extremities, and hit every extremity, okay? So that is the neuro and heat aspect. So then we are going to move into respiratory. So my respiratory assessment is beginning with my inspection. I'm noticing his breathing pattern, if he's using any accessory muscles, his general effort. I'm also noticing his color, and I probably already noticed like if his fingernails were pink. So I'm noticing all that, and then I am going to begin listening. We don't need to do any palpation as part of this quick respiratory assessment. So I'm gonna have him take some deep breaths. And he's taking some deep breaths. And then the base is in the front. And then, more importantly, is going to be on the back. So remember, there are 10 on the back. We start up top. We go down in between the scapula and then across, down, across, down, across, base, base. I think I might be hearing a little something. Mr. Miller, can you take a deep breath and cough? And then I would re-listen and noticing if he has a productive cough, and if so, like what was the sputum. The other part of respiratory that you really need to assess, especially with your in-house patients, is whether or not they're on oxygen, and if they are, you want to make sure that the oxygen is first of all on, and that it's set at the correct setting. Is it on 2 liters, 4 liters? You want to just double check that and do that as part of your initial assessment. Okay? So the last thing that we want to do is do some incentive spirometry teaching to our patient. So Mr. Miller, this is an incentive spirometer. This is to help you expand your lungs, to prevent what we call collapse of little parts of your lungs, and it will hopefully help you with prevent you from getting any respiratory complications. So when you're doing this, I want you to be sitting upright as much as possible. There's a mouthpiece at the end of this, and I want you to put your lips around the mouthpiece, take a deep breath in, kind of like this. And then at the end of inspiration, you want to hold your breath there for 2 to 5 seconds so your lungs are fully expanded, and then take the mouthpiece out of your mouth and breathe out. So you should probably try to do this at least like 5 to 10 times an hour. When you're taking a deep breath in, you should try, this yellow portion will rise, hopefully up to where we have this set. And you'll also notice this yellow piece here should rise in between the smiley face. All right, so then Mr. Miller, can you show me how you would do that? And then he would demonstrate. So that's the incentive spirometry teaching. So respiratory, then we're going to move on to cardiovascular, the CV assessment. So the cardiovascular assessment, some of this you might have gotten already, but we'll begin with skin color and temperature. So I'm looking at his skin color and his temperature, and I'm noticing that his skin is warm, and his lower extremity, again, I might have assessed this already, and when I was doing the neuro assessment, that his skin was warm, dry, pink. I'm noticing the capillary refill on his toes is immediate. Capillary refill on his fingers is immediate. While I'm down here, I would assess his pedal pulses. Remember, the pulse on the top is the dorsalis pedis. And then what's the one behind the ankle?
Posterior tibial.
Posterior tibial. And when I say behind the ankle, I mean on the inside, not on the outside. Right behind the ankle bone. Posterior tibial.
Both of them?
Both of them.
Okay.
We always, if we're doing like a full assessment, we compare sides. That's why we do both, because we want to make sure that they're like equal.
No, like both the pulses I meant.
Oh yeah,
'Cause I know some
in
do
this,
only
yes,
do
we're
the-
gonna do, you mean both dorsalis and posterior? Yes, do both, yeah. Okay, so the next thing that I want to do then as part of the cardiovascular assessment is, so Mr. Miller, I am going to take a listen to your heart now, and there are 5 areas that I want to listen to. So I'm gonna listen to the aortic, which is in the second intercostal space, just right of the sternum. And what am I hearing here?
S1,
S1, S2, right? I'm noticing if I'm hearing any extra sounds or any murmurs. And then I'm going to go to the pulmonic, which is second intercostal space, just left of the sternum. Then I'm gonna go down to the third intercostal space, which is
Mike.
Erb's point. just left of the sternum. And then I'm gonna go to the fourth intercostal space, which is the
aortic or mitral, tricuspid.
Tricuspid. This is review. And then the fifth intercostal space, mid-clavicular line, is the mitral, yes, mitral / apical / PMI,
Bicuspid.
bicuspid.
Okay.
Is that what you said?
Yeah.
Yeah, bicuspid. At this point, I would take an actual apical pulse, and if it's regular, I'm also noticing the regularity of the heart rate. If it's regular, I could count for 30 seconds. And also at this point, we just want you to demonstrate how you would assess for a pulse deficit if that was necessary. And if you're by yourself, you could listen and then obtain a radial pulse. And we're just looking for the fact that they should be symmetrical or together. If you had another nurse, the other nurse could take the apical pulse and you could take the radial pulse and compare. If there's a difference, the pulse deficit would be that difference. Then I'm going to go back, I'm going to switch my stethoscope to the bell, and I'm going to listen again. Fifth intercostal space, mid-clavicular line, generally right under the nipple. Having said that, we all know from our checking off on this before, sometimes you can't hear there because of body build, breast tissue, so you then, kind of listen where you can listen. But I would try in those 5 cardiac landmarks again, apical, bicuspid, mitral, tricuspid, fourth intercostal space, Erb's point, third intercostal space, pulmonic second to the left, and then aortic second to the right. I've also am noticing if my patient has any JVD or jugular vein distension in his neck. That could potentially be a sign of what? If he has bulging jugular veins, right-sided heart failure, exactly. So that's something that you would probably notice. He'd probably have other symptoms as well if you saw the jugular vein distension. So we have already checked the skin temperature, the capillary refill, fingers and toes, and checked for edema. So that's the cardiac aspect of the assessment, and that is worth 8 points. Then we're going to move on to the gastrointestinal part of this assessment. So Mr. Miller, I'm just gonna put your head down a little bit. How's your appetite been? Have you had any problems with nausea, vomiting, any special diet? When was your last bowel movement? Have you had any trouble urinating? Have you noticed any changes in your urine, like the color, the clarity, or any odor? He's like, no. I'm just going to take a quick look at your abdomen, if you don't mind. And remember, the abdomen is from the xiphoid process to the pubis bone, and the middle is the belly button, umbilicus, and then we divide it into 4 quadrants. I'm first noticing, I'm inspecting, and I'm noticing if there's any distension. I'm noticing if there's any fluid movement in the abdomen. What do we call that? Ascites, yeah. And just noticing the general contour. So then I'm going to take my stethoscope on the diaphragm side and listen in the right lower quadrant. If I hear bowel sounds right away, I can just move to the right upper, and then left upper, and then left lower. And then I'll do a quick palpation. Any tenderness here? Okay. So I've asked him about his urine, his output, any frequency, urgency, or pain. If he does have a Foley in, I would look at the Foley catheter. I'd start near the patient and then just make sure that it's not kinked and that it's draining properly. And then you can really look at the urine output in the bag and just make sure that it's adequate and that you're not noticing any changes in color or cloudiness or any blood or anything like that. All right, so then moving on to the musculoskeletal, we are aware of his activity order. What does that mean, your patient's activity order?
If he's bed rest, like if he needs assistance.
If he's up, is he on bed rest? Is he up ad lib? Is he up to the chair 3 times a day? being aware of that. And then being aware of if he needs any assistive devices for him, for his safety, and also for your safety too. You know, we don't want you trying to, or us trying to get him up alone if he needs to assist. So that's really important for, as far as safety precautions for both the patient and for the nurse. If the patient has an order for TEDs or SCDs, we want to be sure that those are on as ordered. And who knows what SCDs stand for? I'm not sure if we talked about this. Sequential compression devices. Do you all know what those are? So they're compression stockings that are motorized, I guess. They inflate and deflate. They usually go over the TED, the white TED stockings, and they also are used to help prevent blood clots and you know, help promote venous return back to the heart, prevent edema. Generally, those TEDs should be removed at least once a day, and you know, reapplied then. And those always have to be reapplied with the patient in a bed position with their legs elevated. So TEDs and SCDs, and then we are going to do a Morse fall assessment. So that will be part of your documentation submission. So I just want you to familiarize yourself with that Morse fall scale and recognize what puts a patient at risk for falls. Falls are a huge issue that we all know we need to prevent. Last, we're going to move on to the skin. Some of this we have already assessed, skin color and temperature with cardiovascular assessment. We're also going to do a quick Turgor, you know, checking the Turgor on his forearm or on the clavicle. Looking at mucous membranes can be another way to give us an idea of hydration. So looking in the mouth, you will do a Braden scale assessment and submit that as part of your documentation. What's the best score on a Braden scale?
6, 18, 16,
19.
20.
24?
Yes.
I don't know how to do math.
4, 8, 12.
So the cutoff we say is, so if a patient has a Braden scale of 22, what would their risk be? High or low?
Low.
Good. It would be low. It's an inverse relation. If they have a Braden scale score of 8, they'd be really high. I believe the cutoff is 18, where like if they're like a 17 or a 16, they're probably at a high or you know a risk. So we want to implement some prevention strategies.
Are we able to look at this scale
Yeah,
while doing the assessment?
yeah. I mean, yes, yeah.
Okay.
But you
I'm
might not be.
memorizing that.
You won't be able to look at it on a test.
Like, so
So you should know, I mean, you know, you might be asked questions on a test about what are the, you know, you should understand what puts a patient at risk for developing pressure ulcers or pressure injury,
okay.
according to the Braden scale.
So it's out of 24.
That would be the best score.
So what is 4 for the friction and shear? Just because it's.
Yeah, so then there's only 3 for that, I believe, right?
Okay. I thought it was on the 20. I didn't know it was on all of these.
So friction shear, there's no 4 for friction and shear, there's only up to 3. So let's see, then we have the conclusion, which is safety. So and this applies to all your patients, you just want to make sure when you leave the room. Lowest position,
Call
the
lights
patient has
and
a call light.
Bedside table bag.
But do they need anything?
Ask if there was any questions about what we did.
Yep, and yeah, so that's it.
Wow.